There have been a few times in my career where patients have told me to F off. Both times that I can remember very clearly had to do with menopause.
Sorry. I probably shouldn't be laughing at this, but
no, it's funny.
I have had so many conversations with patients about like the patient side of this version, and I'm so curious to hear the side of it. Welcome to The Patient from Hell, the show where we discuss real stories, expert insights, and build a community that every cancer patient deserves. Today, we're diving into the world of cervical cancer and HPV with Dr. Shannon McLaughlin-David, also known as SMAC. We explore women's health issues. We unravel the complexities of the patient-clinician communication paradigm. We discuss cervical cancer screening, HPV vaccines, and why guidelines have shifted when it comes to screening protocols of the last 15 or so years. What stood out to me the most was how complicated a clinician's time is during the day, and how for them to do their best care, they have to emotionally switch between giving someone really terrible news and celebrating a key milestone with someone within the course of minutes. I walked away with gaining so much more empathy for our doctors, and I hope by listening to this you might get a few insights there as well. Let's get started. I have a very cool guest with me today. I have SMAC, Dr. Shannon. Doctor, I can't pronounce her last name, and you're going to pronounce it for me, and tell us the story behind SMAC as a way to start.
Oh, sure. So the whole name is Dr. Shannon McLaughlin-David, and that's a mouthful. And McLaughlin is pronounced wrong. If we're being honest, like I had an ancestor who was German, who came to Chicago during World War I and didn't feel like he felt it and fit in. So he changed his name and he spelled it wrong. So it is what it is. We pronounce it McLaughlin, even though it looks different. And that's a lot of backstory, and there's a lot of Shannons in the world. So once upon a time in high school, I started signing my name SMAC. And someone said it out loud one day, and it has followed me ever since. I still sign my name that way because it's faster and I'm impatient. And so my friends call me Shannon or SMAC, or those are the two things that I answer to anyway.
All right, and what do your patients call you?
Well, it depends on the patient and what they're comfortable with and what culture they're coming from. So I have folks who call me Dr. Shannon. I have a few who call me Dr. SMAC, and usually Dr. McLaughlin. But it totally depends on their comfort level and where they're coming from.
What got you into cancer, by the way?
I stumbled into it, to be honest. Like, I always knew I wanted to be a doctor. I can remember my whole life growing up saying, I want to be a doctor when I grow up. And the next question was almost always, are you going to cure cancer? Like, no pressure, kid who just wants to get into medical school. But that was like where the conversation always went. And I always said, I don't have it in me to be an oncologist. So I went to medical school thinking I was going to be a family doc because I really valued the patient-physician therapeutic relationship and the continuity and the growth together. And I went to medical school thinking that family medicine was the only way to accomplish that. Then I fell in love with surgery and discovered obstetrics and gynecology, which comes with the relationship, comes with the surgery. And who doesn't love delivering babies and bringing new life into the world? So I didn't actually experience gynecologic oncology until I was 2 years into my 4-year OBGYN residency.
Oh, wow.
And I fell in love, Samira. I just fell in love. The surgeries were awesome and complex. And I started to realize that someone allowing me to perform a surgery on them was literally the most intimate respectful relationship I could possibly have with a human. And then to have the opportunity to be with them throughout their cancer journey and navigate with them through the hardest, most vulnerable times in their life. I was just so honored.
Wait, okay, so maybe let's do this. Can you talk to us about gynecological guy? I can't even say it.
Oh,
Wow. What types of cancers are included in that world?
great question. And if you ever want to shut down a party conversation, you can be like, I'm a gynecologic oncologist. And then between talking about girl parts and cancer, that will kill a dinner conversation.
I'm a survivor. Don't worry. First
Yeah,
conversation.
you're my girl. Yeah, you get it.
Like, what do you do? Work in cancer. Wait, why? I'm a survivor. Dead silence. It's great.
What do I say? Yeah. But between you and me and our audience, gynonc is different from other oncology specialties because it grows out of obstetrics and gynecology. And OBGYN, as I was talking about before, like why I chose OBGYN was the ability to be a surgeon, but also lean into clinical medicine and patient relationships and do all the things. And so not that long ago, to be honest, and it was like the 1950s when gynonc became, that's not even true. It was more like 1970, 1980, when some OBGYNs realized there was no one to take care of patients with ovarian cancer. And so they just started doing the surgeries and learning about the chemotherapy and doing the clinical trial. Like they just started doing it. And that's how gynonc was born, so that a gynecologic oncologist is someone who should be trained in the systemic treatment of gynecologic cancers and the surgical treatment of gynecologic cancers.
Huh.
In every other cancer type, you have your surgical oncologist and your medical oncologist, but we have the opportunity to be both.
Cool.
It is very cool. It is because it is by its very nature a little more integrated and holistic. So if you have the opportunity to practice both things, like the patient experience is, okay, let's be real, no one has a seamless patient experience in the United States. But we're a little more skilled, to be honest, in offering the closest thing to a seamless relationship, including doing the previvorship and doing the survivorship stuff. That's what a gynonc is meant to be. And the gynecologic cancers are the classic girl parts, as mentioned, the cervix, the uterus, the vagina, the vulva, the fallopian tubes, the ovary. There are gynecologic oncologists, and I was trained to do this, but did not do it in clinical practice, who take care of breast cancer as well. But that's a lot of cancers for one.
And doing systemic and surgery, that's a lot to cover.
Yeah. It's also breast cancer, and I am deeply aware I'm speaking to a survivor. Breast cancer is the most common cancer for women. And what's good about that is that when there are a lot of people, there's a lot of clinical trials that can be done. And then that leads to more innovation faster, so that like keeping up with the guidelines, like we're going to talk about guidelines today, keeping up with treatment guidelines for a breast cancer survivor is a full-time job. Whereas the cancers I focus on are less common, and it takes us like 900 years to fill a clinical trial. And then by the time we get an answer, we realize our eligibility criteria were completely wrong. And so the velocity of innovation has less of a curve, less of a slope compared to breast cancer care.
Wait, can I ask you a really dumb question? Sorry. So you hear about ovarian cancer,
Yeah.
you hear about uterine cancer, you hear
Yeah.
about cervical cancer. I've never really heard of fallopian cancer, vaginal cancer? Like, what are those things? Sorry, are those real?
Yeah, those are things. Okay, first of all, you haven't heard about vaginal cancer and vulva cancer because we don't talk about vaginas and vulvas. Like, it is hard to, this is a sidebar, but true. I worked on a research project with a first generation American from Afghanistan, and we were trying to study HPV and attitudes about cervical cancer screening in the population of folks who were forced to the US at the end of the war. It's a lot to unpack there, but in that, I learned that most of the words for vagina and cervix were words that couldn't be said. They were curse words, and they didn't have good anatomic safe words to use for vagina, cervix. So there's a lot of I'm leaning into this a little bit because of the state of the world right now. There's a lot of extrinsic influence on the ability to study, discuss, know about cancers of the genitals. So I would say that's probably why you haven't really, people don't go around saying like, I had vaginal cancer or I had vulva cancer. They're not common cancers per se. I mean, they are in my world, but they're not in the world. And people don't talk about it. So there's not like a huge survivorship platform. And then fallopian tubes. So quick anatomy lesson, you got your uterus, and then the fallopian tubes are like the tubes at the top. They look like arms and they have little fingers, and the fingers are over the ovary. So my fist is an ovary for those looking on YouTube. And what we had historically called ovarian cancer very, very often is actually a cancer that started in these fingers of the fallopian tube. But we still call it ovarian cancer. For simplicity sake, in talking to people who aren't gynecologic oncologists, honestly, because there's a lot of like geeky molecular explanations of why we thought it was ovarian cancer and why we now know that most of it's coming from the fallopian tube. And it turns out that there is a lot going on in the human body for people with ovaries and fallopian tubes. Like just in that teeny tiny space between the two, there's so much going on that can be a setup for developing a cancer.
Fascinating. Okay, one more question from an anatomical perspective. We haven't talked about endometrial cancer.
Oh, yeah. So endometrial cancer is the most common kind of uterine cancer. The uterus, yeah. So the endometrium is the lining of the uterus. So when people who have uteruses are having periods, that lining is what grows in response to hormones from the ovaries and then sloughs off also in response to signals from the ovary. That tissue that comes out and that bleeding is from the endometrium. So when that tissue turns into a cancer, that's endometrial cancer. And it is the most common gynecologic cancer. And it's the one cancer that continues to increase in incidence and mortality. Despite best efforts at research and developmental therapeutics and et cetera, we're still seeing an increased incidence of that cancer.
Okay, so surgery in the world of I can't say the word. Gynecologic.
Yeah, let's just call it.
All right, in that world, it's primarily hysterectomies, oophorectomies, all of the above.
Yes. Yeah. So it depends on the kind of cancer and where it is, et cetera, et cetera. But I'd say the most common surgical interventions that we do in gynonc would be hysterectomies and salpingo-oophorectomies, which is removal of the tubes and ovaries. What differentiates the skill set of a gynonc surgeon compared to a gynecologist is the type of hysterectomy that we do, the extent of the tissue removed, the ability to evaluate lymph nodes, remove them, and remove other parts of the body. So in the case of ovarian cancer, back in the day when those guys were just trying to figure out what to do, they started taking out everything that was involved in and with ovarian cancer, that cancer spreads around the abdomen really easily. So we could also be doing small bowel resections. We could also be doing splenectomies. We could also be removing parts of colons, and there's even surgeries for recurrent cervical cancers and some others, but like mostly recurrent cervical cancers, called a pelvic exenteration, which I'm going to put a little asterisk with a trigger warning on this, because it's the kind of surgery that removes everything in the pelvis, like the vagina, cervix, uterus, bladder, rectum, tubes, ovaries.
Ugh.
So it's a life changer. So yeah, those are the kinds. And then for vulva cancers, we remove parts of the vulva and do lymph nodes in the groin. And
I don't normally get stumped on the podcast. I feel a bit stumped. And I think the stumped feeling, it's, in breast cancer, there's a lot of conversation about disfiguration and the body as it morphs, and the removal of such a a organ that is so interwoven with being seen as female or a woman.
yes.
What you're describing, though, feels honestly so much worse. It just feels worse, which is why I'm feeling stumped. So
that's, well, thank you for even putting that out there, because 100% all the things, and because we don't talk about it culturally, it is like we throw around these things like, oh, don't worry, like we'll do a hysterectomy, and that is a big deal for a lot of people. And there are a lot of women who connect their womanhood to their uterus, their ovaries, and whether that informs your sense of who you are or not. Removing the ovaries in someone who's premenopausal is cruel. It is a life changer. And, it's really easy from the surgical perspective to say, don't worry, I'll take these out, you'll be done. But that's like, you are dealing with that for the rest of your life.
I distinctly remember having a conversation with my oncologist about whether or not I should have an oophorectomy. I mean, I didn't have ovarian cancer or anything in the gynonc space. I had breast cancer, but the trade had been like guideline-based treatment for hormone. I had triple positive breast cancer. Guideline-based treatment suggests 10 years of hormone therapy. In order to get the first-line recommendation, I had to be on an ovarian suppressor. So from a biological perspective, trade was remove ovary, ovarian suppressor plus aromatase inhibitor. So in either direction, you're switching off. I mean, you're either chemically inducing menopause or anatomically inducing menopause. In either direction, there's menopause.
Yep.
And I remember being so honestly confused by not wanting to remove the ovaries. And at the time, my oncologist was like, you should definitely not do that. That's like the extreme option. Why would you do that? And she walked me back from that option set. But I remember it being, I remember in comparison to 10 years of a drug-induced menopause, it feeling like the right choice. Now, I didn't do it. And my oncologist, like 100% kudos to her for like walking me off that honestly what felt like a gangplank. But at the time, I was not convinced. At the time, I was very much, why would you just not remove it? Just remove it because it reduces the chance of me getting a future cancer. And I just remember that being a very, very hard decision for me.
That is such a good example of shared decision making, because it's really easy to look at interventions based on what's most effective, meaning what's going to prevent the cancer from coming back, without necessarily taking into account impact on human. Because right, the human has a cancer and the cancer is just a teeny part. But the things that we do are life altering. I can totally relate to the concept of I do one thing and it's done and not reversible. And then you have to talk about the risk of regret. I love these conversations with humans because, and my patients and just people in general, because it's really the intersection of whatever they're bringing to the table, whatever goals they have. There have been a few times in my career where patients have told me to F off. And both times that I can remember very clearly had to do with menopause.
Sorry. I probably shouldn't be laughing at this, but
no, it's funny.
We really should talk about this because I have had so many conversations with patients about the patient side of this version, and I'm so curious to hear the side of it. I have definitely heard the patient side of this. I don't think I have heard
it is a formative experience for a physician to be told to F off. Because of something that we say or do with the best intentions in mind. One scenario was early 2000s, right after, pretty soon after the Women's Health Initiative published the first clinical trial. And that's a whole other, girl, we could do all kinds of podcasts about that topic.
Oh man, so many cans of worms in this episode. Oh, so many.
I'm here for it, Samira. I'm here for the cans of worms because I tried to take someone's Prempro. Oh, that's a trade name. Premarin, Progest, whatever. Away from them because she'd had a heart attack. She stormed out of my clinic and yelled to me in the hallway to F off. She was going to find someone else to give her hormones. And then the other time was probably 15 years later when I was a practicing gynonc, and I was talking with a patient about a risk-reducing surgery for a patient who had a BRCA mutation. And the guideline-based recommendations are to remove the tubes and ovaries, in this case, kind of depends, but in this case, it was by the age of 35, or when they're done childbearing and are ready to do the surgery. And this patient was 45. And right, that thing, you just, for the listeners, Samira just made this ooh face. And that's how I felt oh God, TikTok. Because I've spent my whole career taking care of patients with ovarian cancer and I've seen the suffering. And so I was pushing pretty hard. Let's do this. I got a speech about menopause, and how bad it is for the body. And I don't disagree with a single word that woman said to me. And then she told me to F off and stormed out of the Stanford Women's Cancer Center. And I pray that she never got ovarian cancer.
Wow.
But both experiences really, sometimes you need a mallet over the head to really understand how to communicate with patients.
This is a slight tangent, but it's reminding me of it. So I was at Stanford yesterday, part of a class, and I was the speaker there. And It's a mix, 40, 50 kids in the room. Kids, I don't actually mean kids, but some combo of like undergrad, grad, PhDs.
Yeah.
Um, it was about a 3-hour class, and I was the only speaker. And it was honestly me just sitting there and getting question after question, which is super fun. I prefer the one being the interviewer for what it's worth. But anyway,
It does feel like,
oh
my God, I'm being interrogated.
Yeah, exactly. And you have all the hands go up, and it's relatively intense. But one of the questions I got was because we build tools, right? We build maps, and maps, we represent standard of care guidelines, and we intentionally try showing you all your options, not giving you a recommendation. Like that's very much part of the design ethos of the product.
Yeah.
And someone asked me the question of like, what if you spoke to a patient and you know it's the quote unquote wrong decision? You know, right? You have evidence to suggest the decision is wrong. What do you do? And I just remember sitting there, and this is not a clinical audience. This is not med students. This is not survivors. This is kind of a relatively neutral audience, right? It's just like undergrad class at Stanford. And I remember having almost a visceral reaction to this question. And I can get pretty spiky sometimes, and had this like spiky moment. And I was like, honestly, it's not my job. My job is to show the patient their options, full stop. It is their body, their decision. The reason I even say this in reaction to the conversation we're having is I think it's really hard because I get calls from patients, right? And I'm not a doc, I'm not a clinician, but I know at least some amount about cancer, and I get these calls, and I'm just like, oh my God, like there's this moment of like, I want to intervene, I want to correct you. And what I am learning and have learned from having been a survivor is that's just not the job.
Yeah.
That is not the job. It's just not. It's about showing you. It's about showing you near-term and long-term impact in the most neutral fashion possible, and enabling you to make the call that feels right for you.
Yeah.
And I think that is super hard. And in all honesty, Doc, I don't think my docs got that.
You know why?
It was not what happened. I just, I'm a tiny bit of an annoying patient and would show up with data up the wazoo. So we'd have like statistical conversations. So I would kind of get my way based on math, but that was not the setup, right? Despite intentions being there.
Yeah.
So anyway, I want to share that because I
my heart started to race when you posed that question and used the word wrong, because it's a triggering word.
Yes.
And I will tell you that in medical school, which for me was the late 90s, and we were taught that if the patient is making the wrong decision, it's because we haven't counseled them well enough. Now, that's a well-intentioned goal of informed consent. But what's also interesting about where I went to school, which was the University of Florida, go Gators, we just won the tournament, was that I chose that school because it had a very well-developed medical ethics curriculum, which at the time you didn't see at most schools. And I wanted that. I wanted to be challenged and think about things in that way. So I bring this up because it boils down to the concept of autonomy and respecting autonomy. And I, as much as I can understand that in ethical frameworks, in practice, as a physician, where you feel like your job is to save someone's life, and if they die, it's a failure. That's what we're bringing to that conversation, and we don't want to fail. So another formative discussion for me, and you asked about how I wound up in the cancer space. I would make rounds with our gynonc, who became a very important mentor for me. And I would start crying 50% of the time on rounds because he had this gifted way of navigating with patients through end of life discussions. Like we throw around goals of care. I would argue every patient encounter should be about what the patient's goals are for the process. But goals of care is another like buzzword that we think of palliative care and end of life immediately. Moral of the story is I was terrified to go to him with the statement, I want to be a gynoc. Not because I didn't think I had the skills, but because I kept crying on rounds. And he would call it waterworks rounds. But in that conversation, he said, patients are going to die. And I had to come to terms with that. And and the follow-up was, and you can't own that as your failure. And I get the sense that in the world of oncology, not a lot of oncologists have internalized that. It's not your failure.
Yeah, you are. Yes, you're. Yes. It took me about a year and a half after treatment to realize what you just said.
Mm-hmm.
Because I remember having a conversation with someone on our podcast. Actually, this was many moons ago. I didn't know this oncologist. We were talking about tumor boards, and I remember trying to understand. I remember asking him, I was like, why in the world are patients not allowed to be in tumor board? And somehow in that conversation, it was the first time he said the following thing. He was like, you have to remember that the incentives, especially in curative setting, so early stage breast cancer, mostly curative, not always, but mostly.
Yeah.
The system and the clinician training is all about saving your life at all costs. It's the last part of it. It's at all costs. So everything in the system is geared for treat. Everything. And when that patient comes back with a recurrence, peers, the system, look at that oncologist as if the oncologist failed. And I remember that was the first moment where I, in all honesty, gained a truckload of empathy for oncologists in that moment. It took me a year and a half because I was like, what is happening? Like, why are you all pushing me for overtreatment? Like, what is going on?
Oh, yeah.
And I didn't realize it until that conversation. But when I realized it, I was like, oh my God, okay, all right. Because there's shame, right? There's shame, there's guilt, it's my job. I was supposed to deliver and I didn't. And I let this patient down. I let the family down because the patient's not here, but the family's still here. And I can imagine the burden oncologists are walking around when you've had one or two of them. And I had the fortune of now knowing, honestly, hundreds of oncologists, and the stories that stay with them are the stories of loss.
Yeah.
That's the story that they're carrying around. And I watch and I'm like, oh my God, like I understand that. And at the same time, it's about the patient. And there's this like, almost this like counter emotion happening.
Yeah.
But we are so down far a rabbit hole, by the way.
I know, but I'm loving it. Redirect me, like totally. But you can hold both things to be true.
Yes.
You can hold both of those things to be true. Both are humans. And I mean, the reality is, Samir, like we don't get training in how to deal with this or how to cope with it. It's not built into the curricula. Like, oh my God, I just lost a patient. What do I do? Or I just had we go from patient to patient in a clinic, and we can go from like, look, we really got to talk about hospice to like, yay, it's your 5-year survival. And like, we have to pull ourselves together but no one teaches. Well, now I shouldn't say no one, because I was very, very blessed and fortunate to have the training that I did with the people that I did when I did, because we did take care of each other and we did talk about those things. And I've had the experience of like, you know what, those patients are going to have to wait. We are going to sit here and we're going to sit in it for a second and collect ourselves. You as a learner, me as an attending, because it's better for those patients to wait. They're going to scream at us. But we can only be present for them if we pull it together.
What you just said right before this last statement, that you're going from a conversation for hospice to we hit 5 years.
Yeah.
And that's back to back.
Mm-hmm.
I just wanna sort of underscore that a little bit, because I was just talking to someone about this, because with Manta, I now speak to a lot of patients, and in any given day, I'm probably talking to anything between like 5 to 20 patients. And I am a survivor, and I'm not a doc. I'm not in. It's not my profession. It's not my job. Like we build tools, right? It's a little different. But I find it near impossible to make that switch, because that especially the hospice conversation, that one is a gnarly one, right? That one is we have nothing else we can do for you.
Mm-hmm.
To go from that to celebration, an acknowledgement for someone hitting a milestone that felt near impossible to hit, that feels like such a hard emotional experience to have to go through in a matter of what I imagine would be minutes for a doc. Because I imagine you're not getting like a break in between your day.
Samira, it's so thoughtful of you as a survivor to even think about the experience of physicians. Because it's our job to think of the experience of patients and survivors. That is our job. And it's not an easy one, but it is our job. I have come to understand, mostly as a reflection of my time in Chicago, because I spent a little more than 5 years in the state hospital system taking care of the Medicaid population and walking into every room facing an inherent power differential and having to chip away at that to just be able to gain trust. And in the process of doing that and getting involved in the communities around here, I've come to understand survivors and the transition, especially to patient advocacy, as experts. You're an expert, Samira. You're not a doctor. Okay. But you have lived experience that you can't and wouldn't pay for. And you're gaining experience with and you've turned that experience into a platform of advocacy and facilitation for other survivors. That does make you an expert. It's a different kind of an expert, but that's what's beautiful about interdisciplinary collabs, right? Like I could not understand if you started talking about building a platform. I'd be lost, but I can understand how the metaphor of a map helps guide a human through the experience.
I do need to redirect you a little bit, because this was supposed to be about the study.
Right.
And we have 40 minutes in. What was the study? What did you learn?
So this is a study that is big. It's a clinical implementation science piece, which I have such admiration for folks who take this on, because the amount of work and effort and money and intention behind building a clinical implementation study, like those are folks who are trying to change the system to make it better. And it takes all of the resources. So I really applaud the investigators for even attempting this. the moral of the story is the question they were trying to answer is, what is it about the change in evidence-based guidelines that made it such a tough pill to swallow for both physicians and patients? And the evidence-based guidelines we're talking about are cervical cancer screening and prevention guidelines, specifically the screening piece. Historically, cervical cancer screening was really just a pap smear. And a pap smear was something that, for those people who don't have a cervix, I'm just going to describe it because it requires a pelvic exam. It's pretty invasive. It involves putting a speculum into the vagina, visualizing the cervix, and then scraping it. Distilling it down to the bottom line, the guidelines once upon a time were do it every year, start at the age of 18. And that was based on the concept like, okay, we know this has something to do with sexual encounters, so just start at the age of 18. At some point, there was a disclaimer like, or when people start having sexual encounters, you could start earlier. None of that was based on science. It was based on like, it's a screening thing. Let's do it every year. And then as the experts started to come together and actually collect evidence and actually look at the evidence, they realized you don't really have to do this to people every year as long as the result is normal. If the result is normal, you really can get away with doing it every 3 years, because at that point, and this was about 2012, I think, when that paradigm shift happened. And it was a result of more understanding of HPV infections and how long it takes for an infection to turn into a cancer. And that process actually takes years. And as long as someone has an intact, healthy immune system. So the point I want to make, just as a personal point, is that screening guidelines are about recommendations for healthy people without any kind of symptoms. So in that setting, you can get away with doing it every 3 years and not miss anything. Like, you aren't improving the chances of preventing cervical cancer by doing it every year. You're just doing more to the patient and spending more money, and it's not necessary. But that, I remember when this guy, in fact, it was 2012, because it was, I can remember where I was talking about it with my colleagues, because on the physician side, and again, we're talking about physician perspective and patient perspective. On the physician side of things, we're like, oh God, if we don't do it every year, we might lose the patient. We might lose them to follow up. And historically, we do that in medicine. We hold things hostage so people come back to us. It used to be contraception. Like, you can only get your birth control prescription if you come back every year. We're starting to get better about that. But that was the sentiment behind it from the physician standpoint. It wasn't like, oh God, we're going to miss something. It was, we might lose the patient. And then from the patient perspective, it was...
Can you pause there? Can you talk about the actual economic impact there?
The actual
economic impact, because I'm smiling only because the subtext of that is system will lose money.
Yes.
So I just want to sort of explicitly say that is, I think that's important, because I don't think patients understand that. I don't think patients understand that the system makes money by you showing up back to that system. Therefore, loss of follow-up is an economic problem for the hospital or the system.
Thank you for bringing up that point, because when I said the words out loud, I was genuinely talking about me as a physician, like, oh God, if I don't have the annual follow-up, how do I know they'll come back? The extrinsic system, ironically made up of human beings, but we can demonize it by calling it a system. The system is motivated to have people return, get a test, have to come back to discuss the results, have to come back for another test, have to do a procedure, and all of that is in direct conflict with the economic impact for the person, who then has to miss work for another procedure, pay more copays, figure out childcare, like all of the things. So I am by no means a healthcare economist, but those two things are definitely in conflict. And the driver of that is, though driven by humans, it's driven by humans who are not having the conversation with the patients. They're not the ones needing to say no when something's been denied and to a patient. That like they have silos in place to protect the humanity of it all. But there's definitely an impact of, and the lab fees to evaluate the normal, and the normals are the least expensive, because most of these things, even back when these guidelines changed in 2012, the first screening was done by machine, and then pathologists do spot checks. Now those machines are sometimes assisted by AI, and there's like standards for centers to use, but how much human expertise is informing a pretty subjective test boils down to the cytopathologist running things and how many spot checks they are willing and interested to do. Like a pap smear looks like, under the microscope, it looks like pink and blue tissue paper that's been torn up, and then there's some dots. And somebody has to figure out whether that's normal or not. And if abnormal, how abnormal. And then somebody's going to undergo a really uncomfortable exam and procedure if we're calling it abnormal. So we better be right. There's a lot of subjectivity to that particular screening tool, which is why we lean on HPV testing so much more now. Because this study that we're talking about, this was actually conducted 10 to 12 years ago at this point. And the guidelines before HPV testing was a standard that became standard in 2016, I think. We started using HPV testing as a specific tool in addition to Pap tests.
Can you talk about what is HPV? Yes. And what is an HPV test, and how does it relate to cervical cancer?
So HPV stands for human papillomavirus, and it is a virus that likes to live in humans, hence the name. There's about 150 different subtypes of the virus, most of which are completely benign and cause no trouble. Excuse me. A handful of those viruses, though, can cause cancer. And they do it by all of these viruses, when they cause an infection, they insert themselves into the cells. And then, this is really cool, they insert their DNA into ours, at least within that cell. And that gives them the ability to make proteins that cause trouble. And we call them oncoproteins, the proteins that cause the cancer disruption. So in this case, the HPV that 16 and 18, HPV 16 and HPV 18 are the two most common that we know of in the US and around the world that cause cervical cancer. Those specific viruses live in the human genitals, and the cervix is like, okay, we're going to geek out here a little bit. The cervix, for those of you who don't have one, the cervix is at the bottom of the uterus or the womb. And most people use it in, if they're talking about it, it's usually because somebody's in labor and delivering a baby and they're talking about how dilated it is. That cervix, the ability of it to dilate and then shrink and change and respond and be a part of the fertility system, that means there's a lot of cellular turnover in the part of the cervix that is technically exposed to the outside world. It's in the vagina, but the vagina is part of the outside, technically speaking. So that frequent cellular turnover is a setup for mutations to happen, which is what gives the HPV virus an opportunity to cause trouble. Now, most often, 80% of the time, best we know, again, a person's immune system will take care of it and the infection will go away on its own without causing any dysplasia. And dysplasia is precancer. Those are the cells that we want to get rid of before they turn into a cancer. But as it turns out, there's grades to everything. There's like low grade, medium grade, high grade, and the cells can go back and forth, and the immune system plays a role in all of this. And it turns out, if you sit back and just watch this for a little bit, it will go away more often than not. And while we're talking about screening guidelines changing, the guidelines for intervention have also changed over time to be less, take fewer biopsies, do fewer excisions and fewer surgeries, and really lean into the human's immune system doing the job. So all of that is what informed, we don't have to do this to people every year. We can watch it every 3 years, especially in the young population. This study that we're talking about is in women specifically between the age of 21 and 29. And those are the folks who, number one, in all likelihood, their body's going to get rid of the virus. But these investigators couldn't know that because they didn't have the tools to test for HPV. There's a lot of really great innovative science that informs guidelines and how they change. I'm sad to report that it doesn't really change the incidence of cervical cancer. If you look at, there's one curve that shows this is when we started screening everybody. And then this is when it started there's this big slope, looks like a slide on a playground where the incidence just plummeted. And then we've been plateaued for a solid 20 or 30 years. Despite we can test for HPV DNA. Now we're talking about primary HPV screening. And all of these innovations are coming about. It's not really moving the needle. And that's because, in my opinion, that's because the problem is for the people who can't get to the screening. If you have a human being in front of you and they are able to participate in the screening process, everybody's winning. If you have the opportunity to talk to them about the HPV vaccine, because this is all caused by a virus, we have a vaccine that can prevent it. We have a cancer-preventing vaccine.
I love that we just ended up there because we are way over time. Can we summarize, Doc, with what is the current screening protocol and what is the vaccine? Who should be getting the vaccine, in what dose, frequency, order? I forget.
Yeah.
I forget what the current state is.
Yeah. So with regard to guidelines, it's actually really complicated now because we use all of these different tests so that even those of us who are experts in the field, we look at the act to make sure we're doing it right. But if someone has no evidence of HPV infection and has completely normal cytology, meaning the pap smear is normal, then at the very most, they should get this 21 to 29. Those folks should get tested every 3 years. In the folks aged, is it 30? I think it's 30 and above. If both those things are normal, you can go every 5 years. But there's 2 points I need to make because there's a difference between a pelvic exam and a pap smear. And just because you don't need a pap smear every year does not mean you wouldn't benefit from an annual pelvic exam, because cervical cancer is not the only thing that can go wrong. And having a quote unquote expert, a human is the expert in their own body, but having someone who has some expertise in the anatomy, monitoring that every year has real value, even if we can't measure it in cervical cancer prevention. The other point I need to make is that if you read the guidelines, it sounds like people should stop screening at the age of 65, but that is not entirely true. What is true is if you have had 20 years of continuous screening and have never had an abnormality, you can call it quits at 65. Most people don't fall into that category, to be honest. And we actually see lots of people with cervical cancer over the age of 65. And this isn't news, but it's news. People have sex after the age of 65 and could get introduced to a new virus. So it's a point of controversy. And it's a point of misunderstanding, even in the physician community. So I had to make that point. Regarding the HPV vaccine, the vaccine is not an mRNA vaccine. I just point that out because people are talking about it. It's like a completely not live capsule that duplicates the proteins, blah, 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 so that your immune system is doing the job. It just needs the vaccine to build the antibodies against the virus. And it's most effective if the human gets the antibodies before they are ever exposed to the HPV virus, which is why it's recommended in children. And that is also controversial because we're talking about sexually transmitted, whatever. The point is that it's actually easier to get exposed to HPV than people think. It does not require penetrative intercourse into the vagina. So there's really the best protection is if you have a good, robust immunity against it in adolescence, which is why it's a childhood vaccine. We recommend it for anyone, if they didn't get it as a child, to get it up to the age of 26. And then we have safety data knowing that it's safe for people to get through age 45, up to age 46. Now, not every insurance provider will pay for it in that scenario because there's not efficacy data yet, but it is safe to do. And then the other important thing is that it's really necessary for boys and girls to be vaccinated. Those vaccines only work when everybody gets vaccinated, period. So while it is an individual decision about whether or not to do an intervention like a vaccine, vaccines are most effective and only effective in complete eradication if the majority of the population does it. Did I hit all of your questions?
Yes, you hit all of my questions. And we are super, super grateful for you coming on the episode.
I had so much fun. Thank you.
I would love for us to have you back, by the way, because I think we opened up a couple of cans of worms, women's health study, hormone replacement therapy. There are a couple of these things that came up today that if you're up for it, we would love to have you back to shed some light on it.
I love talking about worms. I'm happy to go there.
Thank you so much, Mac. I really appreciate you. Thank you for taking the time. Thank you.
I appreciate you, Samir, all of your hard work. Thank you for what you do.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.